Hello friends, today we are going to discuss about detailed evaluation in substance use, also called as drug use. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at NIMANS, Bangalore. Before I start my presentation, I would like to place this disclaimer. This presentation is for academic and training purpose only. For clinical opinion, please do contact a psychiatrist. Conflict of interest? None. The objective of this video is to introduce to you about the substance use, the harmful criteria, and also the dependence. Dependence means addiction. And also, I am going to discuss about prevalence and comorbidity with substance use. And finally, the components of detailed evaluation. This video is targeted to doctors, psychiatrists, junior resident in psychiatry, nurses, social workers, and psychologists. Let's discuss about the substance use and addiction. Before we move further, we should know there are two types of addiction. One is substance and another one is non-substance. Substance are those which are traditionally used. Legally accepted are tobacco, alcohol. Prescription drugs such as benzodiazepine, examples lorazepam, alprazolam, diazepam, Valium. So these fall into benzodiazepine groups. Illicit drugs are cannabis, opioid, cocaine, stimulants, hallucinogens. So they fall under the substance use group. Non-substance use are those which are in the virtual or digital platform. Examples: pornography addiction, internet addiction, social media addiction, gaming addiction, and also online gambling. In this video, I am going to focus only on substance use. Those basically legally accepted alcohol, tobacco, and illicit drugs. Let's differentiate between use, harmful use, and addiction. Use is basically consuming once or twice. Harmful use, the doctor prescribes him not to use substances because it is causing physical ill health. In spite of knowing that it is causing physical health injury, he continues to use substance is considered as harmful use. Similarly, with regard to mental health, a person continues to use substances in spite of substances causing mental health damage such as depression, anxiety, various other symptoms. So, in simple way, harmful use means a pattern of substance use which causes damage to physical health or mental health. So we have understood about the use, we have understood about the harmful use and colloquially called as abuse. Now we will discuss about addiction. In medical terms, it is dependence. So from here onwards, I'll be discussing as dependence. Dependence, there are two types of criteria we have known. One is ICD, International Classification of Disease. That is one. Another one is DSM V. Both I'll be discussing. As per International Classification of Disease 10 criteria, there are 3 criteria should be met out of 6. These are the 6 criteria. The dependence or addiction criteria, one is craving. Craving means irresistible urge to consume substance. Tolerance. The person needs to increase the quantity of substance to get the same euphoric or kick or effect. That means the person needs to increase the dosage of the substance to get the euphoric effect. That is tolerance. Withdrawal. If the person does not consume the substance, he will have withdrawal symptoms in the form of tremors, restlessness, anxiety attacks, panic attacks, difficult to sleep, tremors, sweating. So various types of withdrawal symptoms can occur. Fourth, harmful use. In spite of knowing the substance is causing damage to physical health and mental health, he continues to use. That is harmful use. Salience. Salience means a person's the whole daily activity revolves around the consumption of drugs. Not only that, he forgets or else he neglects all pleasurable activities for the purpose of consuming substance. That is salience. And the final one is difficult to control. That means he would like to say that I would like to take only 1/4 of alcohol, but he ends up taking 5/4. That means he is unable to control the dose of substance use. For at least 3 symptoms are required over a period of 1 year to make the diagnosis of dependence, that is addiction. Moving to DSM V criteria. Here, at least 2 criteria is required out of 11. Let's know about the DSM V criteria. Craving, that is irresistible urge. Tolerance, to get the same effect, the person is increasing the dosage of substance. Withdrawal, if he does not take the substance, he has withdrawal symptoms, unable to control. He wants to use, but he does not know how to control the amount of substances he is consuming. Salience, all alternative pleasurable activities are neglected for the purpose of substance use. That is salience. Harmful use, that is physical illness. In spite of substance use is causing physical illness, he continues to use. Harmful use with regard to mental illness. That means in spite of substance use causing mental illness, he continues to use substance. Coming to 8, substance use is often taken in a larger amount or over a longer period of time that was intended to take for a shorter but is using for longer duration. 9th, a great deal of time spent in procuring, using or recovering from the substance effect. So that is the 9th criteria. 10th, failure to fulfill the major role at work or school if he is a student or maybe college. And the last one is social or interpersonal problems because of substance use. So out of this 11 criteria, 2 should be present over the past 1 year. Then we call it as dependence or addiction. For the medical purposes, we are using dependence. That means the word dependence is used, not addiction. But however, DSM V further goes and codes into severity. Mild dependence is used when 2 or 3 symptoms are present out of 11. Moderate dependence is considered as 4 to 5 symptoms are present out of 11. Severity, that means severe dependence, is considered when 6 or more symptoms are present out of 11. So this is where DSM V criteria plays a major role not only in diagnosing but also quantifying the severity. Hence, DSM V criteria is best to use both in clinical purposes and also research purposes for the diagnosis of dependence and severity. Now, let's discuss about substance dependence problem in India. There was a very landmark study was done called as Magnitude of Substance Use in India. This is a national survey on extent and pattern of substance use in India. This was done and published in 2019. The Ministry of Social Justice and Empowerment, the Government of India, commissioned the study. All India Institute of Medical Science, New Delhi, conducted this study. This study done a phenomenal survey. 2,11,000 household survey was done. 186 districts of the country was covered. Total 4,73,569 individuals were assessed. This is one of the largest study in the world. Let's move into the results. That each results have been divided into use, abuse, and dependence. For alcohol use, 16 crore people are using alcohol. In that, 5.7 crore have harmful use and 2.9 crore are dependent on alcohol. Dependent means addiction. 2.9 crore individuals are dependent on alcohol. It's not 2.9 individual. Actually, 2.9 crore families are suffering because of alcohol. Moving to the cannabis use. In cannabis, again, 3.1 crore population is using cannabis. Out of that, 72 lakh are harmful users and 25 lakh are dependent on cannabis. Again, it is not 25 lakh individuals. It is 25 lakh families are suffering because of cannabis. Moving to opioid. Again, in opioid, if you look at 28 lakh people are dependent on opioid. That means 28 lakh are dependent, addicted, and 28 lakh families are suffering because of opioid. Moving to inhalant. Inhalant use is nothing but solvent abuse, maybe dependence also, like petrol, RSX, and various other solvents. Here again, 8.5 lakh inhalant users are there. So, huge number. In this, even children form the majority. Imagine this inhalant is considered as gateway drug for hardcore drugs. That means 8.5 lakh children may be using this inhalant. So the number is huge. Moving further, other drugs, 3.2 lakh cocaine dependence, 7 lakh amphetamine dependence, 3.4 lakh hallucinogens dependence. So this is the number what we are talking that needs to be addressed in India. To quantify this problem in India, we need to compare with the world. If you look at the worldwide, 6 to 7% are dependent on one or the other drugs or else substances. That is 324 million. That equates to 32 crore population is dependent. If we compare to India, 8 to 9 million illicit drug dependent in India. That means 80 to 90 lakh people are dependent on illicit drugs. Coming to alcohol, 29 to 30 million. That means 2.9 to 3 crore people are dependent on alcohol. Means if you take both, 35 million, that is 3.5 crore population is dependent either on alcohol or drugs. That means 3.5 crore families in India are suffering because of either alcohol or else illicit drugs. Let's now understand the substance use does not report alone. That means alcohol or drugs, they do not come alone. They come with their friends. Look at their friends. Issue is not just substance use alone. Because the person who uses substance, he will not use only one. He will use multiple substances. A person who takes alcohol may also take tobacco or else cannabis or else other drugs. That means invariably multiple substance use is the norm. It's not the individual who suffers. It is the whole family suffers. In substance use, it is not one diagnosis. It comes with multiple diagnoses. That means he may not have just alcohol dependence. He may have tobacco dependence. He may be using alcohol because of depression. That means another diagnosis is there. That is the reason multiple diagnosis. Not only psychiatric illness, he will also have physical illness. Imagine a person is dependent on alcohol. He will have gastritis. He may have pancreatitis. He may have road traffic accidents. He may have substance-induced dementia. So various other physical illness can be seen. It's not just a medical illness. That means it is not a biological construct. It is also a multidimensional. It causes family problems. It causes financial problem, economic problem, that is, and also social problem. And finally, legal problem also. So please understand, substance use in that comorbidity is the rule, not exception. That means if you see somebody is dependent on substance, check for the other comorbidities because comorbidity is the rule. Substance use comes with other friends. So that is the conclusion. Moving further, see, there is substance use. It will be accompanied with mental illness or else physical illness along with social economic problem and legal issues. So whenever you do detailed evaluation with regard to substance use, look for comorbidities. That's what I meant for this slide. Let's understand about dual diagnosis. Dual diagnosis means it is defined as the concurrent existence of substance misuse and mental disorder in an individual. That means the person has substance use along with mental illness. That is called as dual diagnosis. But it has a complex interaction. That means it's not just a comorbidity. They're just not coexisting, but they interact with each other. For example, a person who is using alcohol over a period of time may develop depression. That means substance use causing depression. However, the reverse comorbidity is also true. A person who has schizophrenia may start using cannabis or else tobacco or else alcohol. That means one lead to other. That means it is a vicious cycle. A person with substance use may develop mental illness. Because of mental illness, he will increase the substance use. That means it has a complex interaction. It doesn't mean that it is a comorbidity. The dual diagnosis has a challenge for the psychiatrist with regard to treatment. At the same time, course becomes prolonged and the prognosis becomes poor. Hence, we need to know about the dual diagnosis. If you look at these studies, the dual diagnosis is present in 60 to 80% of substance user disorders population. That means today you take 100 people who are using alcohol. You can find 60 to 80% people having one more other diagnosis, maybe mental illness. That means dual diagnosis is the rule. If you look at the Western researchers have clearly said that prevalence of dual diagnosis is between 20 to 70%, depending upon the clinical population you are studying. For alcohol, these dual diagnoses may be different. For opioid dependence, the dual diagnosis may be different. Hence, it is a range 20 to 70%. Moving to the dual diagnosis prevalence with regard to specific diagnosis. Personality disorders 20 to 50%, depression 12 to 88%, and anxiety disorder 10 to 24%, and bipolar disorder 50 to 60%. So depending upon the various studies and various drug used, and depending upon the population surveyed, where it is surveyed, whether it is in the community or in the district hospital or else in the tertiary centers, the dual diagnosis percentage varies. If you look at the dual diagnosis in India, one of the best studies done in PGMR, that is PGI, they found that dual diagnosis was present in 32%, affective disorder 12%, anxiety disorder 11%, and psychotic disorder 5%. So, dual diagnosis do occur even in India. Let's move into the detailed evaluation of substance use disorder. So please keep this in mind. The prevalence, the comorbidity, and also the differentiation between harmful use and dependence. Time taken for assessment. Brief assessment or screening is done in 10 to 20 minutes. If you want to do a detailed evaluation, it will take 20 to 60 minutes. For follow-up, 5 to 10 minutes, depending upon the clinical acumen of the professional, the type of assessment done, and also what we are looking at it. So depending upon that, the time is required. Here we are discussing about detailed assessment. When you are doing detailed assessment, at least you should have 20 to 60 minutes in your hand. So we will discuss about detailed assessment. The objective of the detailed assessment is to determine the type and severity of the patient's substance use, understand the patient's perception of their condition and readiness to change, identifying the comorbid psychiatric and medical conditions, identifying the barriers and facilitators to reducing the substance use, and finally, to inform and develop a plan for management of substance use and dual diagnosis. These are the various 11 components of detailed evaluation. First one is demographic details. Second one is chief complaints and history of presenting illness. Third one is complications. Fourth is reason for consultation. 5 is past history. 6 is family history. 7 is personal history. 8th is pre-morbid personality. 9th is mental status examination. 10th is cognitive function. And 11th is formulation. Let's discuss each one of them. Detailed, that is basically demographic details. Demographic details basically name, age, father name, gender, advance directives N are present or not, date of admission, under which Mental Health Care Act section has been admitted, address, mobile phone, email, photo ID. If you are able to have a photo ID, you may be tomorrow you can do telepsychiatric consultation, because if the ID is there, you can cross verify when the person comes on telemedicine. Who are the informants? Whether the information is reliable, adequate, those is very essential to comment, course of this illness, and precipitating factors. So they fall into demographic details. Further, moving to chief complaints and history of presenting illness. In chief complaints, look for substance use, how many substances he is taking, since when he is taking. It has to be presented in chronological order. You need to evaluate for each substance use in detail. Here you are going to mention those substances. If he has abnormal behaviors, since when, you will document here. Harm to self and or others. And finally, complications. So each one of these chief complaints has to be presented in chronological order. Moving to history of presenting illness. And here in the history of presenting illness, please remember, you will start with how he initiated. That is, age of onset of use. When the daily drinking started. When the morning drinking, that is eye-opener substance use, that is whenever he wakes up, he wants substance. That is morning or eye-opening substance use. Pass out, blackout, binge drinking needs to be documented when it is happening. So that's the initiation. Moving towards the type and frequency. What is the way he is using the substance? Whether he is using in the morning, afternoon, or in the evening. Quality and quantity. That is, quality means the type of substance he is using. Is it cannabis? Is it alcohol? What type of alcohol? What is the brand? What is the quantity he is using? Route of administration, especially with the drugs, whether it is IV drugs, whether it is inhaler, whether it is snorting. So depending upon the route of administration has to be commented. And the last use of the substance, if possible in hours or in days. And dependence criteria should be checked, whether he has craving, tolerance, whether he has loss of control, whether he has withdrawal symptoms, whether he knows that substance is causing harm but he continues to use, and finally salience. At the same time, check for what is the maintenance factors, why he is using this substance, and also check for what was the worst consequences he had because of the substance use. For each substances, you will go through all these steps, that is initiation, type and frequency, quantity and quality, route of administration, last use, dependence criteria, check for each one of them, maintenance factors, and worst consequences so far he had because of the substance use. And every substance, you will go through each substance. And each substance should be documented separately. And the relationship between each substances should be documented. For example, as soon as he gets up in the morning, he may use nicotine, that is tobacco, smoking. By the time around 10 o'clock after the breakfast, he may take cannabis. By around 11 o'clock, he may use stimulants. And in the evening, alcohol and opioid. That means the relationship between each drug should be documented. And also perception of use, whether he defends why he is using or else he is guilty of using substance. So what is this perception about the substance use is very essential, whether he is ready to change or whether he is resistant to change. And also the locus of control, why he is using substance. He says because of the weakness, because he has got addiction, or else he says because his family problems, because of the financial problem, because of the job problem, because of the family problems he is using substance. So you need to know the locus of control. Moving to the third component, that is complications. Here you need to check for various complications. There are 4 types of complications need to be checked. One is medical, psychiatry, legal complication, and socioeconomic complications. And try to find the relationship between substance use and these complications. First, we move to the medical complications, or else you can call it as organicity because of substance use, or neurological problems because of the substance use. These medical complications may be accidents, head injury, blunt trauma to the body, seizures, maybe because of metabolic reasons, because of withdrawal, or because of head injury, insomnia, body ache, headache. These are the medical complications, and various pathies can be seen. That is neuropathy, radiculopathy, myopathy can be seen whether these medical complications are there. And also check for Wernicke-Korsakoff syndrome in the person who is using substance. At the same time, check for various GI problems, CVS problem, or else respiratory problem. So all these complications need to be checked before we move further. Moving to psychiatric complications. Check because of substance use whether he is having depression, whether he has mood symptoms, whether he has psychotic symptoms, whether he has anxiety disorder, whether he has personality disorders, or else deliberate self-harm or suicidal attempt. Check the relationship between the psychiatric complication and the substance use, whether the substance use came first or else the psychiatric symptoms came first. So these need to be checked in detail, and also know whether these symptoms occur under intoxication or during withdrawal symptoms, or when he is in sober period also he has, and whether these psychiatric symptoms and substance use are unrelated. That means you have to make efforts to know the relationship between the substance use and the psychiatric complications. Moving to the legal complications, you need to know whether the substance use is voluntary or involuntary. And if you are able to pinpoint there is a legal problem, check whether during that legal problem, whether it was a voluntary consumption or involuntary consumption. Legal problems can be criminal or civil. Criminal is basically legal issues regarding violence, stealing, gang activities, or else arrested because of number of times, how many times he was arrested, whether the FIR was lodged, number of cases pending against him, what is the present legal status need to be documented. Coming to the civil problems, it may be economic problem leading to loan, check bounce, property issues, divorce, contract issue issues, and domestic violence. So these are the various legal complications that can be seen in a person with substance use. Further, the social complications. Need not say substance use or drug use causes enormous social complications such as job loss, occupational loss, or else disciplinary action when he is using substance at the workplace, economic loss, social status may slide down, people may not respect him, his own children may not respect him, his spouse may not respect him. So social status may decline. Children affect on the because of the substance use. What is the impact on the children's mind, education, whether the marriage is occurring or not, or else people refuse to marry his children because he's using alcohol very highly or he's using drugs. At the same time, check for fights with the families, friends, relatives, neighbors. So those kinds of social complications need to be captured. Moving to the fourth component, reason for consultation. This is a very important component because many a time the person could have come to the hospital because family had been forcibly has brought him here, or else he is motivated to quit and he has come. So reason for consultation, who initiated the consultation, what is the locus of control of substance use, whether he has come voluntarily or involuntarily, what is the expectation of the patient and the family members need to be documented. Moving to the fifth, that is past history. Past history plays a very crucial role in substance use. Check whether there is any medical illness in the past or else whether there are any psychiatric illness in the past. If those illnesses like physical illness and mental illness is there, check what is the relationship between the substance use and this physical illness and mental illness. Look for any history of admission in the past and treatment for substance use disorder. For example, if the person was admitted in the past to a rehabilitation center for substance use, check whether it was voluntary or involuntary, where he was admitted, duration of admission, and also after the admission, for how many days he was abstinent from the substances, and if there are relapse, what is the reason for relapse needs to be captured, because same factors which has caused relapse in him will operate now also. Hence, reason for relapse in the past gives a very good indication how to manage this patient. if the person has severe withdrawal symptoms, if this person has severe craving, or else this person has severe anxiety disorder, that means the reason for relapse, if you are able to pinpoint, that means you should focus on the factors operating relapses, and you have to minimize those factors which are operating for relapse. Coming to the perception of substance use in the patient needs to be captured, and that needs to be addressed in therapy. Moving to the life charting, because as I said, 50 to 70% of the patients will have one or the other comorbidity. How to capture in the life chart? If this is the life chart, y-axis and this is the x-axis, and you can see the duration in the x-axis. If you look at this, this is the alcohol use. The person started alcohol use in 2014. In January to maybe around August, September, it was less. Slowly it increased, and in 2016 and 17, in that he stopped, and again he resumed alcohol use. If you look at this, cannabis use. In 2014, he started using cannabis. During 2014, for some time, he was abstinent because of some reason, and you need to know why. And he continues to use cannabis. In spite of he had stopped alcohol use, he continued to use cannabis. Coming to the mood symptoms. During 2015, he had a depressive episode, and in 2017, he had again a manic episode that is marked in red. And looking at the dysthymic symptoms, from 2014, he is having low mood, which was there till 2017. As soon as the mania onset occurred, the dysthymic symptoms also disappeared. So this is how the symptoms are captured. Along with that, you are going to capture the life events. The father died during 2015, during which he increased the alcohol use. At the same time, cannabis use was continuing. And further, you can see at the height of the manic symptoms, he lost his job. So this is how you are going to capture the life charting, because the comorbidity is the rule in substance use. Moving to the sixth component, that is family history. In family history, you need to do a genogramming charting, that is pedigree charting. Family history of substance use you will document, family dynamics, family coping, family's perception of substance use, whether they are critical, who is the main caregiver, and their coping skills, and if there are domestic violence needs to be documented. This is how the genogram is documented. Here is the patient, female patient, 18-year-old, she is using the substance, and that is the first, you can see the pedigree charting starts from there, and this is the second father and mother and their sibs. And finally, if you look at the second generation, or else the final third generation, the depression and dementia you can see. So this is the 3-generation genogram to be documented, to know about the family history of substance use and how it is operating, and also look for the family dynamics, how the parents are looking after him, if there is a spouse, how the spouse reaction to the person's substance use need to be documented, and family therapy may be one of the intervention for substance use treatment. Coming to the personal history. Personal history is very essential because substance use has genetic background. So you need to look for birth and early milestone development, behavior during childhood illness like ADHD, conduct disorder, externalizing behavior need to be documented and checked. Schooling and college, whether he had SLD, selective learning disorder, whether he had truancy, stealing, lying need to be captured. Occupation, whether he was able to hold the job, whether he used to use substance during the work needs to be captured here. Menstrual history, sexual history has to be captured. That is, how many partners he had, whether it was planned, whether it was protection, whether it was one night stand, those kind of things. Basically, to capture high risk sexual behavior is essential. Marital history, and also look for any internet use, gambling, and also online gambling, gaming need to be checked. Moving to the 8th component, that is pre-morbid personality. As I mentioned earlier, the substance use also has personality disorders. To check for the personality, you have to know whether the person, what was the personality prior to the start of substance use. Ask the patient to describe his personality. Ask him, what do people pursue about your personality? At the same time, Collect the information from patient's family members, friends. Before you do that, please do take consent from the patient. Further, inquire for each of the trait he reports. If he says, I'm a very jovial person, ask for the examples. If he says, I'm very meticulous, ask for the examples, because examples are very essential to make the documentation of the trait or else a PD. You need to comment on each of these 11 components of personality assessment. One is social relations, how was his pre-morbid functioning, whether he was taking responsibility, what is his coping with stress, how he coped with stress, intellectual activities, hobbies, mood, character, attitude to work and interpersonal relationships, energy and initiatives, fantasy life, and habits. So these are the 11 different pre-morbid personality components need to be assessed. Coming to the ninth, that is general physical examination and mental status examination. General physical examination should be thorough because patient with substance use will have one or the other physical comorbidity. Hence, when the person comes for general physical examination, see whether there is any smell. If the person has a peculiar odor, which is very common in cannabis, and the person has used cannabis, if he is a smoker, the tobacco smell can be found. If a person has consumed alcohol, you can smell the alcohol on his body. So that means what kind of smell the person has when he comes into the examination. Look for the vitals, lymph node, thyroid. Look for retinal examination and also look for conjunctival injection, because that will give a clue for his substance use, whether he is using cannabis or any other drugs. Look for RS, that is respiratory system, cardiovascular system, per abdomen, and central nervous examination. They are very essential. Look for IV marks. If the person is an IV drug user, look for his thighs, elbow, hands, and legs, whether he is injecting IV. Look for nose. If he's snorting, are there any injuries, head injury? Look for deliberate self-harm marks on the body and also tattoo. So these needs to be assessed in general physical examination. It should be thorough because you should not miss any physical problems during the admission into rehabilitation center and getting into problem. Hence, before you admit into a rehabilitation, please check for general physical examination thoroughly. Moving to mental status examination, first and the foremost is general appearance and behavior. How was his dressing, whether he came voluntary, whether rapport was built, eye contact made, abnormal movement if it is there, when was the last intake of substance, whether he had any withdrawal symptoms now, that need to be checked in MSc. Moving to the psychomotor activity, whether it is increased, decreased, restlessness, normal, need to be commented here. Look for the speech, whether it is coherent, relevant, tone, tempo, reaction time, volume. At the same time, get a speech sample. Ask him to talk about a festival or else his country, or else talk about his place, his job, about his family. So free speech sample is very essential. That means you need to ask a open-ended question. Moving to thought, look for formal thought disorder, stream, possession, and content. If he had psychosis, don't miss this thought problem. Moving to mood, check for what is his subjective mood and also objective, and comment on the congruent appropriateness, range, reactivity, and lability of mood. Perception. Please never forget to ask about auditory hallucination and visual hallucinations, because substance withdrawal can cause all type of hallucination, and it can cause hallucination in any sensory modality. Look for other phenomena like somatic passivity, depersonalization, derealization, which are very common in withdrawal symptoms. Moving to the cognitive function, that is the 10th. Before you plan for any management, cognitive assessment is essential. Look for whether it is conscious, whether it is alert, whether he is alert, drowsy, whether he is stuporous, whether he is intoxicated, whether he can do this cognitive function tasks. Check for his orientation, time, place, person, because your management plan depends upon the patient's orientation. If he is going to delirium tremens, especially with regard to alcohol, you need to be aggressive in management and you need to do IP care. So depending upon the orientation, the timing of withdrawal, your orientation should be exactly examined and documented. Attention, concentration, Memory should be checked. In coming to intelligence, judgment, and insight. Here, the insight, whether he knows whether he is having substance use problem, whether he has any other psychiatric problem, whether he had any medical illness, and what is his reasoning or logical explanation about this problem need to be documented. 11 component formulation. Dear friends, formulation is very essential to communicate your plan of management, your diagnosis, differential diagnosis, and prognostic factor occurs in formulation. Formulation moves from one professional to another professional. Hence, formulation need to be very crisp and also should communicate your diagnosis, differential diagnosis, plan of management. So here it is doctor's own medical assessment of the case based on facts of arriving diagnosis and plan of management. Technical terms should be used here. Significant findings in mental status examination, general physical examination, and cognitive functions will be documented here. And also, your adequate dose of treatment, duration of treatment, what is the plan for future treatment, what are the investigations, investigation findings, psychosocial assessment and their findings, point in favor of diagnosis, against diagnosis, differential diagnosis you are going to document, and also the prognostic factors you will be documenting here. Don't forget to have a plan of management in future. What will be the psychosocial management, how the family members will be involved, what will be the prophylactic management will be communicated in formulation. To conclude, my dear friends, detailed evaluation of substance use disorder requires to be done in a systematic way. And at the same time, you need to check for comorbidity. Check for physical comorbidity, look for any mental illness, look for other comorbid substance use. At the same time, never forget to check for comorbidity even in follow-up, because comorbidity can be seen even during follow-up. At the same time, educate the patient and family members regarding the expectation and also course and outcome. Please keep your door open for the patient with substance use disorder and also educate the family. The person in the first treatment setting only, the relapse rate will be 70 to 80% in the first 6 months, and educate the family to bring him whenever there is a relapse. At the same time, if the patient does not have the perception of that it is a problem, do a psychoeducation, provide him about the literature regarding the substance use and the problem, and also communicate him. The door is open for him to come and seek help anytime he requires. So my dear friends, substance use disorder is a challenge, and the morbidity is very high in our population. The person with substance use disorder does not suffer alone. The whole family suffers. That means the community also suffers. So please use your valuable time in treating patients with substance use disorder and look for comorbidity and have a good management plan. Involve family members in the treatment. Thank you very much for giving your valuable time. Stay safe.